Welcome to the Sustainable Clinical Medicine podcast. I am your host, Sarah Smith. I am a practicing rural family physician and the charting coach. This is the podcast for physicians and advanced practice providers who are ready to step back from the busyness of their clinical day to share ideas, question everything, and redesign their clinical day. We are redesigning clinical medicine to create sustainable clinical days and create time for our lives outside of medicine. Join us for discussions with world experts who are helping design sustainable models of clinical medicine and the physicians or clinicians who have discovered or designed sustainable models of clinical medicine for themselves.
Hello and welcome back, everybody. Today we have with us Dr. Sarah Dalton to talk to us about some wellness in systems and other exciting pieces. Welcome. We'll let you introduce yourself.
Hi, Sarah. Thank you very much. My name is also Sarah. I'm a pediatric emergency medicine specialist from Sydney, Australia, and I have a number of other roles that pretty much are involved in supporting doctors to do their best work and to have sustainable careers. So I'm loving this opportunity to talk to you.
Perfect. Tell us about your journey through medicine, things that were challenges along the way, other pieces about your career that we can learn from.
I think it's fair to say that I've always been a bit of a square peg, trying to be round hole. From an Australian perspective, the way I like to describe myself is that my spirit animal is a platypus, which, if anyone doesn't know, is an animal that's got lots of strange bits that go together. It's got a beak and it's got webbed feet and it's got a tail like a beaver. And when they first found it in Australia, I believe that the British Museum didn't believe it was a real animal because they didn't think those things could go together. And so for me, I am a bit like that. I have lots of things that don't normally go together. So I like pediatrics, I like acute care, I like thinking about systems, and I love learning outside of medicine. So I do lots of different things, and I love all of them, and I think they contribute to each.
Yeah. Tell us about then the clinical journey for you.
Yeah, so I started off with a very traditional clinical journey. I went straight from school into university to study medicine. And all through university, I had lots of different leadership roles and was loving everything. Every time I had a specialty or a rotation, I really loved it and thought that was what I might do. I ended up working in a rural area. I had a scholarship to be a rural general practitioner, which I thought would be perfect for being able to do a little bit of everything. And I came back to Sydney to do a diploma of pediatrics with the idea that it would make me a better GP. And then when I got there, I just really loved working in pediatrics. And so I stayed in Sydney, I stayed in pediatrics, but I ended up doing emergency medicine, which is not really in some ways that different to what a lot of rural and general practitioners do, and are able to continue to have the diversity of different areas of interest and knowledge. And I think that's probably one of the best descriptors of my whole career, actually. I've always liked to have a real breadth of interest and experience.
Got it. Okay, right. Then when you were in medical school and university, you said leadership roles. What sort of leadership roles were you doing?
I think, like many people in leadership roles, you can look back and see that you've always had a leadership position. And I think there's actually some good evidence that says that if you look back and you had leadership roles at school and then in university, you're very likely to continue in those roles in the future. So I'm sure a lot of people listening will have had that experience. I mean, for me, it started right back when I was in primary school and I was on the school representative committee, and I won't go through all the rest of them. But then at university, I was the president of our medical students association, and then that got me to meet a lot of global medical student leaders who now are still, especially in Australia, Australian medical leaders who I met with initially 30 years ago when I was at medical school. So it was a great way to start learning about the system and how things work and different perspectives, and then a little bit about how, I guess, management and governance works alongside just being a leader.
Got it. Yeah. What about as you moved further into your training, registrar levels? What else was happening there for you?
I think the best way to describe it is I was always just very curious and also interested in what could be different. I once described myself as an optimistic problem solver with an overdeveloped sense of responsibility. And I think that all leaders need to have that. I was very often standing at the end of the bed and, providing the care for the patient and just so aware of the system. I think a lot of emergency doctors are like that because you work on the interface between the community and the hospital. And so you can really feel when the system's not working. And I was
Mhm.
interested in how do we improve the experience for our patients, which often starts by experiencing and working with clinicians and people who work in the hospital or in the healthcare system, and particularly around those systems. So when I was training to be a pediatric emergency doctor, I got interested in how I could do quality improvement. And this was such a long time ago. This was in the early 2000s, and I started doing a Master's of Quality Improvement. And at the time, it wasn't something that doctors in Australia really did. In fact, I remember one of my mentors said to me, "That's very interesting. Which particular quality do you want to improve?" So no one had really heard of it back then. But to me, it was just very practical. And I've always been very practical and tangible. And if there's a problem, like I said, optimistic problem solver, try and fix it and don't complain about it, be part of the solution. And so I got involved in quality and safety roles. And then I ended up being involved in a New South Wales health organisation called the Clinical Excellence Commission and set up a paediatric quality and safety program. And then that got me thinking even more about systems leadership and how we can empower leaders really and clinical leaders to make a difference. Then I went on to have a Fulbright scholarship in clinical leadership and spent some time in the States and learned a lot about, I guess, different ways of being a leader and a clinical leader. And that's really been the foundation of what I've spent the most of my non-clinical career doing since then.
Got it. So tell us about quality improvement. So you're in the emerge and you're seeing a kiddo and you're trying to not complain about it, but noticing that challenge of what do I do with them? How do I send them? Where do I connect them to advocating for patients? It sounds like that's where it kind of drove that I want to make this easier or better. Does
Mm-hmm.
that sound fair?
Yeah, for sure.
Where you were seeing that like difficulty or challenge. Um, and then you found quality improvement as a master. So what was it about quality improvement that seemed to be the thing that might help fix this when you're in the clinical situation?
I think the thing about quality improvement is very much that it's a structured approach to approaching an issue and working a way through it.
Mm-hmm.
And that, many people would be familiar with a PDSA cycle or a quality improvement cycle. So stopping to think about what is the problem? How do we describe it? How do we measure it? How do we brainstorm some solutions? How do we pick the most effective one? And then how do we test it? And small
Mm-hmm.
tests of change. And it's really interesting because now I work as a coach and I spend a lot of time coaching. I've done some qualifications in coaching. And actually, to me, it's a very similar improvement cycle. It's just with an individual and an individual choosing actions as opposed to a system and working out what the best system action is.
Yeah. When you were doing this quality improvement work, did you then take it back to your department and start working on some things?
Yeah, absolutely. So there are two early projects I remember that were really inspirational for me. And one was the very first one. Again, it was a very long time ago before people were really talking about consumer experience. I was interested in the experience of people in the waiting room because, unfortunately, patients spend far too long in our waiting rooms and not enough actually time having the care. And the project was called Consumer Experiences of Waiting in Emergency, which was Q, which I was very, very proud of at the time. But really, it was the first time I'd really stopped to think about what it must be like with a sick child when you're in the department and you're waiting to be seen and there's nothing for them to do, nothing to entertain them. They're hungry, they're tired, they're in pain, whatever else. Everybody in that department was doing absolutely the best they could to look after patients everywhere, including in the waiting room. And we had processes to make sure that patients had connections with nurses and other things and were reviewed in the waiting room. But it was an opportunity to sit down and actually ask patients and consumers what it is that they needed and what they wanted to see done differently. So we approached that with a quality improvement cycle from, collecting some information and brainstorming some options and then implementing them and made a difference with how we changed the environment in the waiting room. And that was, again, that was a very long time ago that we did that. The other one that I got involved with after that, which I found really meaningful, was around looking after children with possible appendicitis. Because what we knew was that most of the children actually probably didn't have appendicitis. And the ones that were easy enough to send home and not have to get a surgical review was fairly straightforward. But for those where we were just like not quite sure and maybe we need to do a little bit more, especially working in a hospital where you're lucky enough to have surgeons who can come and see children, we were inviting the surgeons to come and provide an opinion on a number of children. But then there would be such a long delay, and the delay would be through taking the bloods, things within the control of the emergency department. How long does it take for the numbing cream to work, and then for the blood test to be taken, and then the blood test to come back, and then someone to look at the blood test, but then beyond that, phone call to the surgeon, and when the surgeon comes, and then sometimes the surgeon would want an ultrasound. And the whole thing was taking so long, and very few of those patients seemed to end up needing to stay in hospital. So it was about how do we improve that? And I think that's a good example of why I was interested, because it made a better experience for the patients, and it also made a much better experience for the clinicians. And it made a better system improvement because it meant that we didn't have people clogging up our departments because we were moving them through more quickly. I think that's probably a really good reflection of why I was interested in the improvement work.
Yeah. Tell us about the waiting room changes. What actually ended up happening out of that little cycle there?
I'm really showing my age, but this was in about 2002. So
Yeah.
it was a really long time ago. And in some ways, it's not at all surprising that nothing's really changed. You know, really what patients wanted was they wanted to know what was happening. They wanted
Mm-hmm.
to know how far they were progressing in the queue. They wanted to have some idea of how long it would be. It's not that
Mm-hmm.
people expect to be seen straight away. They just want to know. They wanted to
Mm-hmm.
have access to things like food and drink and entertainment. And they wanted to really just, I guess, know where to go if they had any questions. And
Mm-hmm.
so we ended up spending more time, with people in the waiting room, being able to provide information to patients. We changed the environment a little bit and provided some activities. We got some sponsorship from a local organisation who provided a little activity bag for the kids, changed up in the little playroom that they were working in, and then made it clear where people could go to get drinks if they needed something to drink, if they were allowed to drink, that is. So
Mm-hmm.
they were fairly simple things, and things that I'm sure lots of waiting rooms are still doing or still trying to do today.
Or may have lost that
Yeah.
good knowledge and not having that now. It'd be interesting for us to, who are working in emergency departments, to actually walk through our waiting room and see what it looks like,
Yeah.
knowing that there has been previously quality improvement work done here, and what could we be doing that could help our patients through this process too. And then with the appendicitis kids, what was the outcome in terms of time from start to finish after doing all of this work together?
Yeah, there's a very significant decrease in the amount of time that children spent waiting in the emergency department. Some because we effectively, with review and brainstorming and engaging everybody as per the usual process, we came up with a much clearer process about the steps that were required. And so we were able to discharge some patients without having to wait for surgical review at all. And then for the
Mm-hmm.
ones that we all agreed needed surgical review, there was a few changes, not only including these are ones you actually have to review, because I can
Mm-hmm.
understand you're a busy surgeon, you've got lots of things to do, you're in theatre, you've had 15 calls for emergency for children with tummy pain, they're not going to be 15 cases of appendicitis. So it was
Yeah.
about making sure that we were clear on the patients who did need to be reviewed. And
Yeah.
then when the surgeons were able to come, I think they were able to give better advice about following the guidelines for what needed to happen. And actually, we looked at some other structural changes, like putting on some registrars who were then primarily available as the first point of call to come to emergency, instead of everybody needing to be in theatre and emergency at the same time. So there were a number of different changes, which clearly involve lots of people. It's not ever about one person making a change. That's why it's hard.
Yeah. Yeah, but it could starts that development of flow charts and protocols for at least your emergency department, for the staff coming in. Everybody knows the protocol for appendix. That makes everything faster and easier, because then if you're new to the area, for instance, it's just easier to start if you've got those
Yeah.
organized places. So yeah. Fabulous. Okay. And then you went into some other areas, some clinical excellence. Tell us more about that. What did that look like?
Yeah, so all the way along in my career, I've been working clinically, and that's always been a really good grounding job. It reminds me why I do what I do, and I love being connected to patients and clinicians. It's always been a good joke for me that working in the emergency department is my 4-hour job, because that's the
Mm-hmm.
timelines that we work around in emergency departments in Australia, is trying to make things happen within 4 hours. And then I've had a number of systems leadership roles, which I joke are my 4-year jobs, because everything takes so long, but those kind of changes take a lot longer. So I've had a number of roles in government where we've had a health department with different parts of the department who look after quality and safety and appropriate care, looking after models of care. I also had a role in digital health, and currently I'm working in education and training, which I guess are all, all those jobs I've had for 4 or 5 years, which again shows how old I am. But all those things we know are components of effectively improving the system and supporting the doctors and nurses who are looking after patients to do their best work, because they don't have the time at that moment to think about the best model of care for this patient, or has the person that I've asked to come and do this procedure actually been trained to do it. We need to get all those things done behind the scenes so that in the moment of the patient care interface, things are easily able to be happening as best as possible straight away.
Yeah. What are some of the government level, organization or system level things that you've been involved in, just to help us understand what it really takes to move a system or an organization yeah.
Well, one of the big projects that I've recently been working on, which is a live project, is introducing a single electronic medical record across the whole of New South Wales Health, which is an enormous undertaking. It's over 200 hospitals. And as we all know, electronic medical records mean that every single person who works in the hospital needs to know how to use them. It's not just the doctors and nurses, it's everybody. And just to be clear, this is an enormous priority project with a huge number of very talented people working on it. And I am just a small part of that team. But it's been a really interesting exercise. And for me, I think in many ways, an opportunity to apply the knowledge and experience that I've had over those many years of doing improvement, because this is a statewide improvement priority that is pretty much not negotiable for everybody. So all the concepts of what do you do around clinical engagement, how do you help people understand the need for change, how do you get the systems and processes right, how do you look after individuals and not burn them out because they're so sick of change, but they actually do want things to be better. There's so much wrapped up in it. But for me, the fundamental belief I have is that our electronic medical record systems can either make you or break you. And none of them are either end of the spectrum, like most do a pretty good job. But the better the electronic system is, the more it allows us to spend time with our patients and makes all the things that are automatable easier if done really well. And so this is an opportunity to do it really well, to make things a little bit better and easier, not only for our clinicians, but everyone in the hospital and also for our patients.
Got it. Okay, so having a doctor at that high level of looking at, were you part of the decision about which electronic health record to go with, or that was already predetermined by a team? How did that work?
So that was very much a team decision with a very robust process behind it. But there were quite a number of doctors and nurses involved in that decision, through an escalating governance process. But there was really good to see the emphasis on asking, I've now learned the digital language, asking users, frontline users, to actually provide feedback on what they thought would be a good system. Because as we know, there's a lot of competing priorities in health, and it's difficult sometimes. Like, we have the trouble we have with being able to provide great care for patients sometimes is that we might be constrained by the system, or we might be constrained by the resources, or the fiscal environment. Whereas similarly, we want to do the best thing for clinicians in choosing this record, but it doesn't mean that we can, doesn't mean that we have access to absolutely everything that we want, and we are still constrained by systems and resources and other things. So it's a priority that has to be set, and a conversation around balance and compromise, if you like. But I'm just so delighted that New South Wales Health were able to have clinicians at the table in that conversation, because very often these decisions are made by technical people and finance people, and then the clinicians find out too late and they just get what they get and don't get upset.
Though keeping them happy it is going to be a difficult battle. Like you said, that physician engagement, clinician engagement, everybody's got to be on board. It's not, this is a compulsory change that's coming down, and you're going to have to be part of it, and not burning people out, I think, at the coal face, right, with the new systems. Super important, and difficult work. Not easy at an organization level.
No, it is. It's really, really hard. And I think there's a number of lessons in how to do that well, but the very first one is to be authentic. And by that I mean which is why it was really easy for me to work on this project, even though I'm not a digital expert by any means. But actually, being able to say I'm not a digital expert to clinicians I'm not a digital expert, but I really believe in this, that makes you far more credible with them. And so I think it's probably good that I wasn't a digital expert. I genuinely, authentically believe that this can make a difference and will make a big difference. So I think being really honest with people is important. And I say that first because I think the next thing is to think about what's in it for me, for the individual that you're talking to. But you do have to do that authentically. Otherwise, it appears that you're being a bit of a salesman and you're trying to manipulate them. So rather than just only focusing on the amazing thing this is going to do for you, let me tell you how great this will be. I think you have to be authentic, but you do also need to understand that people are coming with their very own perspectives, and there will be things that will be good for them. And there will be things that will be hard for them. And I think it's important to say that, but also to say on balance, once we get used to this new system, I think it will be better. And to try and help people see that vision of how it will be better for them and for their patients. Because ultimately, most clinicians and people in hospital, they definitely want things to be better for them, but they care so much about their patients that if we can also share that things are going to be better for patients because of this intervention, then I think that helps.
Yeah. I know it's an ongoing and rolling out process. Having just done that in Canada, in Alberta, right before moving back here, it's just fascinating to see that it's about to start kind of in a big area of Australia as well. And it's being rolled out in Queensland as well, as also kind of coming on board with the whole electronic medical record in the hospital system. What about the interface from hospital to community doctor? How has that been considered, or is it being considered yet? Or is that kind of a next phase will be?
I mean, I think the short answer is that everybody acknowledges that that is such an important interface and we don't do it well. And I think at the same time, it's acknowledged that it's pretty tricky to do it well, not because we don't care, but
Yeah.
because, bringing together, as it sounds like you've been through this in Alberta, bringing together 22 hospitals is a pretty much a 10 out of 10 difficulty challenge as it is. If you try to bring together 220 hospitals and 450 general practice systems, you're pretty much not going to be able to be successful. And what we do know about goals is that they have to be achievable to some extent. So it's not at all to say that it's the next horizon because we don't care. I think it's absolutely the number one thing we'd like to get better. One of the things that I think is a great principle is that ultimately, if we work towards having patients who control their information and they have access to their records and then they share it with whoever they need to see it, then it doesn't need to be the doctor in the hospital sharing with the doctor in the community or the nurse in the emergency department sharing with the nurse in the community centre. It's the patient who's sharing whatever they want with people. So in principle, I think there might be different ways of how we solve this in the future without having to have everybody having access to the same record.
Yeah, got it. Yes. Yeah, one of the big challenges, I guess, with the Alberta electronic medical record that they went with was how long it took to do everything within that program actually required such significant changes in it, at least rurally for us within our rural environment. We actually had to give up a community physician to have a second physician always on at the hospital to be able to do the inpatient management because it just took so much longer. We couldn't do our usual workflow of go see our few patients in hospital, then go to the clinic. It was just too big within this system that was very, very large. It was a very, very large program to work with.
Yeah, I mean, that just reminds me, I did say I'm very practical and action-based, which I am, but there are some theories which I find fascinating and very relevant, and complex adaptive systems is one of them. And the reason I'm saying that is just because I think healthcare is, the quintessential example of a complex adaptive system, which pretty much means we play whack-a-mole every time we try and fix something, right? If there was a simple solution, we would have found it. So if you fix one and you pop it down, something else pops up, and you fix that, and then something else pops up. So the law of unintended consequences is one that I think is really relevant to this kind of approach, because with the EMR, no doubt there are lots of things that have been improved, but at the same time, there are unintended consequences, and it pushes something out somewhere else that can't quite be fixed because there's not one simple answer, as much as we wish there was.
Yeah. It's just the fascination of watching a big system, a big organization, and the kind of flow on effects, the ripple effects that you're right, unintended consequences that have a big impact at that sustainability level for the physicians and clinicians on the ground.
For sure.
Okay. Let's talk about then education and training, or digital health. How is the education towards the patient? Like that's tricky too, right? Getting that right, because educating patients to understand and advocate for themselves, to be able to access these digital health records, that explanation of it is private, it will be kept private, it's not going to be available to everybody to see your information. Has that factored into what you're doing now?
Yeah, absolutely. I mean, the two headlines that go through my head are health literacy and digital literacy, both
Yeah.
of which we know are huge topics in themselves. But I think to some extent, whatever whatever happens going forward, both things will be improved because our digital systems are in use and we will have to use them, and therefore we will be better at using them because we have no choice. Whether we're a digital native or not, we're going to have to get used to it. And then when you get used to it, you get better at it. So I think for most people, they will become more familiar with these systems. And also because information is available, and maybe you can now see what your full blood count shows, which means you become interested in what your hemoglobin is, which means that you then go and Google what hemoglobin is. And I think that means that you then are able to empower yourself and increase your own knowledge. And I think our patients are pretty good at that. And I really do think that we'll have a different type of conversation because we have such informed consumers or patients or people who we work with, at the same time as clinicians being more informed themselves with more information. And in some ways, the challenge may be, how do we manage that amount of information? That old ignorance is bliss thing doesn't sit there anymore. And sometimes it's actually worse because you have too much information. I think maybe that's the challenge we need to prepare for.
Yeah, yeah. With all of these other roles that you're doing, plus you're still working clinically, how do you make it sustainable for you? How do you contain the work and outside work balance for yourself?
That's one of the hardest questions that I think I've grappled with almost my entire career. I think there's a lot of things that are important. And the first one, as we know, is to have insight and awareness and commitment to change. And I've had periods in my career where I haven't had any insight or awareness to the fact that I'm not working effectively. So I do try to have some self-compassion and acknowledge that even being aware of it and wanting to work on it is a very good first step, because I think we sometimes find that we expect ourselves to be magicians, to do the normal, and I'll speak for doctors, but I know there's a lot of people like this. The normal doctor thing is to be, at least a national expert in your field, if not perfect patient care with great reviews from your patients and clinicians, who's probably got a special interest area, who may well, outside of your clinical role, have other healthcare roles where you're an educator or a researcher or a teacher. And outside of your professional healthcare role, you've probably got involved somewhere in your community, or you're committed to a local gym, or you're doing something else that you're involved with, or you might be involved with the school. And all of that at the same time as I'm really taking good care of my health, I'm sleeping well, I'm exercising all the time, I'm eating very healthily. And I think we set ourselves really impossible goals. And that's not to say that it's okay, we can just do it and not worry about it. It's more to say, I think we do have to be a bit kind to ourselves and not expect that I'm going to do all the things I love and have perfect boundaries and perfect balance. Having said that, I do think it's important to be aware of it. And the thing that makes a big difference for me is being very conscious of my boundaries. That doesn't mean that I'm always able to stick to them. But I think, it's better to have a boundary and knowingly violate it than never have a boundary. And by that, I mean things like, when do I answer emails? When do I check emails? When do I say I'm available and not available? And the other thing, which I think has been my most important learning, which I share as, it's important to walk the drink stops. And I can explain that because I've done a little bit of running in the past and quite a number of half marathons. And when I first started out, I was so keen to be fast and get to the end, I'd never stop. And then the older I got, the slower I got, the more I needed to walk the drink stops. So most long runs have a table of drinks where you stop every 5 kilometers. And if you try to run and drink at the same time, it goes everywhere and you make a mess and you don't get half of it in anyway. So I learned fairly early on that I needed to walk the drink stops. And that's my metaphor for how I think, been able to be somewhat successful in continuing to do what I love in my career, is that you need to actually stop and take some time out occasionally. And I have had periods of long leave. I've had every 3 or 4 years, I've had about 3 or 4 months away from work, and I've done travel or I've spent time with family. And it's not possible for everybody to do that. I'm extremely lucky being a public servant. Effectively, we have long service leave, and I'm able to do that. But at a 3 or 4 year cycle, I do that. But then even within my, 12-month annual planning, I pretty much use all my leave and make sure that I have a break every 3 or 4 months. And I really think that's important. Got to have some downtime. One of my amazing colleagues, who's an amazing Australian doctor called Emily Amos, who you might want to listen to, talks
Mm-hmm.
about the importance of systole and diastole.
Mm-hmm.
And as doctors, we know that you've got to pump, but you can't pump if you can't fill. And so that concept of being able to stop and refill and re-energize is super important. Don't have to do it all the time, but you do have to do it.
Mm-hmm. I like that. That's very helpful, just to see what the balance looks like. Because as you're doing different and interesting work that's fascinating or just big, like you said, it's a 10 out of 10 problem, it can be all consuming.
Yeah,
So
for
it's
sure.
just interesting to see the balance. Tell us about the coaching that you're doing. Who do you work with and what do you help them with?
So I mostly work with doctors, but I work really with a lot of clinicians from different backgrounds. And I really love that, actually. I really enjoy working with people from different backgrounds. But in the work that I do with doctors, I would do everything from working with doctors who are trying to pass exams, and performance coaching and managing your, I guess, your approach to the exam, whether that's in the lead up and holding yourself accountable to the study, or whether it's managing the nerves and the performance on the day. And then I also really talk to doctors about whatever their challenges are. So for many people, that can be about well-being and making sure that they're doing their self-care appropriately. For some people, that's about career planning at different phases. Either I'm, thinking of exiting clinical medicine, or I'm in a new job, or I'm going to transition to retirement. But I do a lot of work with leaders as well. I love
Mhm.
working with clinicians who are leaders. And then that just brings in all the normal leadership challenges, like how do I manage up? How do I have difficult conversations? What do I do with my team when they're not on track? What do I do with myself when I realize that I'm actually not very good at speaking up? So there's a number of things that I do work in, and I really enjoy that. It's really a privilege to hear from clinicians about what they're working on and what their challenges are. And I think the biggest reflection I have from that is what I said to you before, which is that we all have such high standards that I talk to so many people, and when they tell me their stories, I genuinely think how amazing they are. And the next thing that comes out of their mouth is usually something along the lines of, I'm not good enough, or I don't think I'm good enough, or I'm worried I'm not good enough. And that's, that's a real shame. But I do think that's part of high performing careers, and that's why I think coaching is really valuable, so you can work through that and have someone work with you to shine the light on what you're doing really well, and think about the things that you've achieved, not just the things you have yet to achieve.
I love that. I love that. So if somebody was in the day-to-day struggling with their clinical work or their role within their teams, they're just having that moment of, this is unsustainable, this is too hard, I can't keep going at this pace. Where do we start? What would be some of the things that you would be looking to assist them with in terms of places to go, things to think about, first steps?
Yeah, that's such a good question. And I think that it would depend on how long I was talking with this person, but I would be thinking about short-term goals and long-term goals.
Mhm.
So in short term, I'd be thinking about, is this really, I can't even show up to work today? Or
Mhm.
is this, I'm going to have to make a big change in the next 12 months? Both of
Mhm.
which are reasonably short term when you think about your whole career.
Yeah,
But for
yeah.
some people, it's long term. It's like, actually, I can't work in this area anymore, both either professionally or geographically, or whatever it is. So I think whatever they are, I would encourage you to think about the other. So if you're really concerned about the long term, the
Yeah.
most helpful thing I find is to help people chunk it down into something that's achievable now, and what's the first thing they need to do. So I might not be able to help you unpack the fact that you've decided to become a surgeon. That means you're going to be on call 24/7 for the rest of your career right now. We might be having a conversation in a year's time about whether you want to do that. But what do you need to do right now that's going to help you get through the next week or the next month? And then, the coaching approach, as you know, is to say, what do you think would be the most important thing that would make a difference? Or what would
Mhm.
be some of the things that could make a difference? And start with some brainstorming, and then look at that list and say, what's one of the most important things? and then try to chunk that down into what does that exactly mean. So it's not just I need to sleep better. It's what does that look like? How can you be specific about that? If you had to write yourself a written goal that was specifically going to be at what time, by what time, how many times, and how will I measure it, how would you do that? Which feels very transactional. And I said before, I'm a very practical person. But I think you have to be practical. You can't just go to bed every night and say, gosh, I've got to get better at sleeping. You've got to, and also focus on what you've achieved. So set yourself a simple goal. And if it is this week, I'm going to turn my light off before 10:30, 3 nights this week. At the end of the week, if you've given yourself 3 ticks for those 3 things, then you've moved forward. And then the following week, you refine the goal and maybe make it a little bit harder or a little bit more frequent. So start small and build up would be my best piece of advice.
Love that. That's very helpful, because I think that you're right. We like perfection. We like to know that we're going to be able to do this, and we like to have the biggest goal. You're like, nope, little and small. Yeah, totally. Where do people find you if they're looking to work with you or learn more?
So I work with an amazing organisation called Capstan Partners when I do my coaching, facilitation and consulting work, and they're easily foundable online at capstanpartners.com.au.
Perfect. Good. Is there anything we didn't talk about that you'd like to leave with our listeners?
Oh, gosh, that's a good question and hard to know where to go. I think what I'll leave you with is one of my favourite icebreaker questions is, what did you want to do when you grew up? And thinking back to when you're at school, or maybe when you're choosing what to do at university. Because I think not only is it kind of fun, depending on what it is, and if you ask people and have that conversation with each other, you might learn something about someone. For example, one of my great colleagues who I work with in Capstan Partners, Rita, who actually runs the organisation, she wanted to be an astronaut. Like, she really did. But not just like, I'm a kid who wants to be an astronaut, but she was thinking about how could she, and I never knew that. So it opens up a great conversation. But the interesting thing about it is, what do you think was the thing that you liked about that the most? And what does that say about your underlying interests and strengths? And how does that show up for you today? So, for example, I actually really wanted to be an actress. Yeah. And not just because it was fun, like it was fun, but I liked being in the team. I liked being on the stage. I liked doing creative things. I really enjoyed that opportunity for improvisation. And I can see now that I do a lot of those things. I improvise, I talk to people, I work in teams, and I can see that link. And probably that's a big part of why I did pediatrics, because it was a little bit about putting on a show and having fun. But I would never have been able to see that going forward. I can only see that going backwards. So as a fun dinner time conversation, next time you're looking for a fun fact about someone, ask them what they wanted to do when they grew up.
Perfect. Love this. Well, thank you so much for being a guest with us today and your pearls of wisdom. And have a wonderful week, everyone.
Thank you so much, Sarah.
Bye.
Thank you for being part of the Sustainable Clinical Medicine podcast. If you'd like to learn more or join us to help you get home with today's work done, go to chartingcoach.ca. There you'll find all the information on the premier Lifetime Access Charting Champions program that is helping physicians get home with today's work done, with all the proven tools, support, and community you need to create time for your life outside of medicine. We would love to see you there. Until next time, thanks for listening.